Okay, this is the second half of the pain management lecture. We are going to talk about the use of medications to help manage a woman's pain during labor and delivery, possibly. The objectives, I know they are pretty broad objectives, but what you need to know is you need to know your medications, you need to know side effects, you need to know when you're working in labor and delivery, how are they going to affect the mother? Also, what implications do they have for the newborn? Because remember, you have two patients, okay? So what we need to know before we really get into the different methods are we need to be able to know the difference between analgesia and anesthesia. So analgesia are medications that they do not take the pain away. They don't block the pain. They just change how we feel or we think we feel the pain. They just change our perception. Anesthesia are those methods that actually block the pain pathway. They take the pain sensation away completely. Okay? Sedatives. Sedatives are not a pain medication. They don't alter the pain. They don't take the pain away. They are used in the latent phase if we have a woman who is very anxious about her labor and she is not dealing well with her labor pains. Now remember, this is early in labor. This is the latent phase. And so her contractions really are not that strong. They're not that close apart, but she's already having a really difficult time. When a woman becomes really anxious, it can affect her labor. Because she's anxious, she's kind of fighting against her labor, and it just doesn't allow the process to move naturally. So there will be times where the healthcare provider may order a sedative that you see on the screen. Basically what it does is it either just helps her relax, or it may even cause her to go to sleep and take a nap for a couple hours. We call that a therapeutic nap. And the thought is, after she has relaxed or slept for a little while, she will wake up in a better state and better prepared to deal with her labor. Okay, there are a couple adverse effects that can happen. I have never seen the amnesia occur, but remember that everybody reacts differently to medications. And also, I have not seen really the infant affected because we're giving it early in labor. And usually by the time the baby is born, that medication has worn off and is not in the system anymore. So some pain medications that we can give to our woman during labor to help her perceive her pain a little differently. Demerol is one of them. This used to be the go-to pain medication. It is not used as often anymore, and it's just really just helps her relax during contractions. Now, we're not going to start giving pain medications until she is in the active phase. Because if you remember during the labor lecture, I had mentioned that if she's in the latent phase and her labor pattern is not well established or she's not in true labor, if we give pain medications, it can either slow down her labor or completely stop it. So we typically do not use any of our pharmacological pain methods until the active phase. Okay. Just remember, as if you, when you're always giving a pain medicine, make sure to monitor vital signs. Remember that you have a second patient, your baby in utero, so assess fetal heart rate. One of the things we need to pay attention to when we are giving pain medications to mom in labor, especially Demerol, if we're giving a narcotic, is it can cause respiratory depression in the infant immediately after birth. So we typically do not like to give this medication within 4 hours after, 4 hours before delivery. Okay, now that's not so easy to predict. So if we do give a narcotic and then she does go on to deliver within 4 hours of the pain medication, we just want to make sure that everybody in the room is aware that she did receive this medication, and we have equipment necessary to care for the baby and personnel from either the NICU or the nursery who are trained to care for infants in case that baby has respiratory issues after birth. Your more common pain medications that are used nowadays are your opioid agonist antagonists. So Stadol, Nubain. Stadol is very common. It's probably the most common one out there right now. You can see the doses. I am not going to test you on the doses on the exam, but you probably might see these medications as far as possible side effects. What would you need to do as the nurse if one of these side effects occurred? And it might show up as one of your med dose calculation questions. Okay. One of the other things with your Stadol Nubain, especially Stadol, is once again, it can cause respiratory depression in the newborn. So if we are within that 4 hours of giving the medication to mom, we want to make sure that we are prepared in case baby has any respiratory effects. Okay, so we'd want to make sure that we have resuscitation equipment and we have personnel trained to care for the baby. If the baby does happen to have some respiratory depression because mom did receive Stadol or Demerol within 4 hours of delivery, Narcan should be easily accessible on the unit, possibly in the labor and delivery room locked up. This reverses respiratory depression. Okay, you can see the dose. It is given by weight. Many times the newborn has not been weighed at this point, so the doctor may look at the infant and estimate a weight. Okay, we can give a couple doses. It's usually very effective, and many times one dose is enough to reverse the respiratory depression. One key thing you need to remember about Stadol, right here, underlined. If mom is dependent and is abusing opioid pain medications, if she was given an opioid or a narcotic during labor, and that baby has respiratory depression, we do not use Narcan. It will put that baby into a very quick and a very severe drug withdrawal, because if mom takes those drugs during pregnancy, then baby has been taking those drugs and now baby is addicted, and we do not want to just push that baby into a withdrawal state. Okay, so we would have to deal with the respiratory depression in other interventions such as oxygen, maybe ambu bagging. Okay, so initiating some artificial breaths until we can get that baby to respond. Okay, another form of management is actually using local anesthetic. So this would be at the time of delivery. Okay, so think of it, and I'm sorry if this kind of is going to make you a little weird next time you go to the dentist. Think about it when you go to the dentist and you have a tooth pulled and they give you a local injection in your gums of Novocaine. It is the same concept. They can do it 2 different ways. So if they're going to just use a local anesthetic for maybe an episiotomy before they cut the perineum, or to repair laceration, they're just going to don't look at this right now. They're just going to give a local shot in this area where they are actually going to cut the tissue. A pudendal block. This is not used as often as it used to be, but there might be some doctors still out there that are using pudendal blocks, so this is why it's included. This is an actual nerve block. So you can see this long needle. And then the syringe is filled with Novocaine, basically. And it is injected actually at the pudendal nerve. So it is going to numb this whole area. So this was the initial way that we would numb the area for an episiotomy. We're going to talk about a forceps later in the semester. They may use this for a forceps delivery because that can be painful. Okay, so this is just an injection of a Novocaine to numb areas of the perineum, basically for episiotomies. Now what we're going to talk about is something that has become very common in labor, an epidural. Okay, I can't even tell you how many women have epidurals. I can't remember the percentage off the top of my head, but it has just become very common for women to use epidural anesthesia because it takes the pain away. Believe it or not, if it's done properly, they don't feel their contractions at all. Okay, so it takes that pain sensation away. I'm going to show you a little diagram in a few minutes that will show you where it is injected. So it is injected through the back, okay, into the epidural space between the lumbar vertebrae. It is a mixture of actual anesthetic material. Sometimes they will also put opioid pain medication in there so that as the anesthetic wears off, she also doesn't feel or perceive her pain as much. Okay. One of the key things you need to know about the epidural, it is a continuous infusion similar to an IV in an extremity. There is a catheter that is inserted into the epidural space. It is taped in place, and then the tubing is connected to a pump similar to an IV pump, and there's a continuous infusion of medication into that space so that she does not feel her pain. Okay, medications that might be used, and then one of the good things is it does provide very good relaxation because she does not feel her pain at all. She's awake. Her level of consciousness is not affected like a pain medication. If you give Demerol or Stadol, it can affect their mood and their level of consciousness. Disadvantages. There are disadvantages to an epidural, and I don't think we do a very good job of teaching women this ahead of time. Because it not only takes away the pain sensation so that they can't feel anything, it can affect their movement, their range of motion, their mobility. So once they receive an epidural, they are stuck in bed. They cannot get out of bed. They cannot ambulate. Okay. During the insertion process, it can cause a hypotensive state. It can cause their blood pressure to drop too low, which is going to affect circulation throughout their body and to the infant in utero. So many hospitals, I think it has become a standard practice that any woman who is going to receive an epidural has to receive an IV bolus of, it's usually about 500 milliliters before the epidural is inserted. And this is just hopefully to give a little fluid boost to prevent a drastic hypotension. Okay. If they do experience a state of hypotension, depending on how low their blood pressure drops, if it drops too low, below your 90/50 or 60, then they may order an IV vasopressor in order to bring that medication up. The key is to prevent the hypotensive state by giving that 500 milliliter bolus. The fetal bradycardia, you're going to see if she has hypotension. One of the other two key things to remember when you have a woman who has an epidural, because she has decreased sensation in the lower half of her body, she really can't feel if her bladder is full. And remember, we talked about how a full bladder can slow down the labor process. So since she can't feel when her bladder is full, she doesn't know when she has to void, and therefore it can possibly affect the labor progress. So many physicians will order a Foley catheter for their women with an epidural. Okay, so they can't get out of bed and they can't void on their own. They have to be catheterized. The other big thing is because they can't feel anything in the lower half of their body, when they get completely dilated, effaced, and it's time to have the baby, they can't feel their contractions, so they don't know when to push. They can't feel how they're pushing. So it is up to the nurse to know when to turn the epidural pump off. and stop the infusion. So that way the medication wears off, and then the woman is going to have to feel her contractions so that she knows when to push and where to push. Now, as I mentioned before, everybody reacts differently to medications. We all metabolize them different. We excrete them at different rates. So there is not a true science to when do you turn that epidural off. There isn't necessarily a policy that says turn it off when she's 8 centimeters, when she's 9 centimeters, when she's 10 centimeters, because it's not going to wear off the same for every woman. So nurses who work in labor and delivery over the years, they kind of develop their own sense of when it's time to turn it off. And hopefully we can turn it off in a timely fashion so that she can feel her labor when it's time to push. If she can't feel her labor pains or her contractions and she can't push effectively, it can slow down the delivery at that time. And then they may have to intervene with other methods that we will talk about later on. Okay, so insertion. This will be done in the patient's room. Anesthesia will be called. Anesthesiologist or nurse anesthetist are the ones that insert the epidurals. This is also the same insertion process if she's going to have a spinal anesthetic, which we're going to talk about in just a minute. So in order to get into the correct space between the vertebrae, the spine needs to be curved, okay? And it can be curved with the woman either laying on her side, bringing her knees up, or she can sit on the side of the bed and lean over, okay? It does the same thing to the spinal column, all right? So this is, you can see, this is the actual insertion process. Then this is the patient with an epidural in place. The catheter is going in here, and if you see this little tube underneath the tape, that is the catheter that is hooked up to a pump over here and is continuously infusing the medication. Now, one thing you have to remember is during the insertion process, she is in labor. She's in active labor, at least. And so she's having contractions. Anytime someone is going to insert something through the spine into one of those spaces, it's very important that they stay still. So your role not only is to help the anesthesiologist with equipment or things like that, you need to help your woman in labor remain calm and use her breathing techniques so that she doesn't move during the insertion process. Okay? This is the diagram I had referenced before, just to show you where the epidural is in place. So you can see that it's here. This one is under L5, and it's right here in the epidural space. Now we're going to start talking about a spinal anesthetic that is used for C-sections. This is up higher between L3 and L4, and it actually goes in further into that subarachnoid space because we want spinal anesthesia is used for C-section, so for the surgical birth. So you can see for an epidural, in order for the woman to not feel her contractions, we want her to be numb basically from the umbilicus down. If it's a spinal, we are going to perform surgery on the abdomen. So the spinal creates a numbness basically from the bottom of the chest down. So that's why it is given up higher and it's given in a different space. Okay? So spinal anesthesia. It is the same concept as an epidural. Okay? It is a pain medication and an anesthetic that is injected, as you just saw, into the subarachnoid space. It takes the pain completely away. It takes all sensation away so that they can actually cut for the surgery. The difference with the spinal is it's a one-time injection. It is not continuous. So it only lasts for a couple hours during the surgery. Okay? And you can see these are just different medications that would be used. Advantages are Mom is awake during her surgical birth. So if she's having a C-section, she can be awake. She can hear her baby's first cry. She can see her baby. She could possibly hold her baby. Okay? Spinal anesthetic is used for sections that are planned or scheduled ahead of time. So this is not going to be used in an emergency because it takes time for anesthesia to insert the spinal anesthetic. Disadvantages are they can have a reaction to the pain. They also can have a hypotensive situation just like the epidural. Okay, so they may receive a bolus ahead of time, or they may be infusing a bolus as they're giving the epidural, and it's important to monitor blood pressure. Something else to pay attention to are respirations. Remember I showed you that the spinal stop sensation from the bottom of the chest down. Sometimes, if the spinal anesthesia is given a little too high in the spinal column, it can actually cause paralysis of the chest and ineffective respirations. Okay, I have not seen that too often. I think I've only heard about it once on my shift, but it can happen. Something that is a little more common is a spinal headache, and we're going to talk about that in just a minute. And then because it completely relaxes, they can't feel anything, it can cause issues post-op with bladder retention and uterine atony, where the uterus might relax too often. So spinal complications, as I mentioned before, they can have hypotension, so they will receive a bolus. If their blood pressure still drops too low, things that we would be probably helping the anesthesia with, and they may give a vasopressor. So this hypotensive situation can occur with an epidural and a spinal anesthetic. I had mentioned a spinal headache. So what can happen is when they are inserting the needle, I'm going to move to the next slide for a second. This is the subarachnoid. Here's your subarachnoid space. So when they insert the needle through here to give the medication, they insert the medication, they pull the needle out, then this membrane usually will self-close. Okay? That's what happens most of the time. What can happen sometimes is the puncture in this membrane does not close. So now it creates a leakage of cerebrospinal fluid out of the column, which changes pressures in this system, which creates a spinal headache. And a spinal headache, from what I've heard, is the worst headache that a person can ever have. It can cause ringing in the ears. It is to the point where the woman, it literally hurts to lift up their head, open their eyes. They become sensitive to the light. It can affect their vision. It's very painful. So, and as you see, it can begin right away. Within 24, 48 hours, it can last for days or weeks. Okay. One treatment that they will intervene if pain medications do not work and the symptoms are so severe is they will do what's called an epidural blood patch. So what they do, let's say this is where they injected the spinal anesthetic. So this is where the puncture is in this membrane, and it's open and it's allowing fluid to leak out. So what they're going to do is they're going to have a syringe of actual blood, and they're going to go into the same place between the same two vertebrae that they gave the spinal anesthetic, and they're going to inject an amount of blood. So what we're hoping is that that blood forms a clot, which then pushes on here and then stops the leakage. Okay, so it creates a clot that gets up against that puncture and it stops the leakage, which then will allow the pressures in the spinal system to equalize, and that is how the headache then is resolved. All right, general anesthesia. So general anesthesia is when we are going to put the woman to sleep and paralyze her entire body. We only use this for emergency situations because if we give mom general anesthesia through gases and IV injections, then baby is also receiving these medications. And so we only use this when it's a matter of emergency and we have to have baby out quickly because baby or mom's health is at risk. When we do general anesthesia for emergencies, we typically have that baby out from anesthesia to birth in probably 5 minutes, okay? This is an emergency situation. We need baby out. We also don't want to, we want to decrease baby's exposure to the general anesthesia, okay? So as I mentioned, or I may have mentioned earlier, is as the nurse in labor and delivery, if you are helping a woman with her pain management, you really need to know your meds. You need to know the labor process. You need to know side effects. You need to know possible complications. You need to pay attention to when your pain meds are given and when she delivers. And if any narcotics or opioid antagonists are given and it's too close and she's giving birth, now you need to make sure that everybody is aware of the possibility of that infant experiencing respiratory distress, depression, making sure that all necessary equipment and medication is available. Okay, so you need to know your meds. Right here, same thing. Make sure that you're monitoring the appropriate vital signs. Don't forget that you have to monitor baby also. Also monitor contractions and any cervical changes because when you give pain management, pain medication, sometimes it can relax her and so that her labor is more effective. And then always know when that pain med was given in relation to the time of birth. And then this is just a sheet that I have created that helps break down when different kinds of pain management methods can be used during the labor process. And there is a Word document on Blackboard that also has this information so that if you want to print it out. Okay, that's it.